2023. It's great to see you all here. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today, and for me, that is the Wurundjeri Woiwurrung people. I'd also like to acknowledge the traditional owners of the lands and waters across Australia, and please feel free to put into the chat if you would like to acknowledge the lands that you are on. And I pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generations. So firstly, just start with a little housekeeping regarding Zoom. At the conclusion of the talks today, and we have 2 speakers today, we'll have some time for Q&A. But if you have questions, please feel free to submit them throughout the seminar using the chat function. And that can be opened using the chat tab at the bottom of your screen. Today's seminar will be recorded and uploaded to our YouTube site and website. So if you do not wish to be recorded asking a question, just keep that in mind. But otherwise, we always welcome people to put their cameras and unmute themselves if they have a question. So today we are very lucky to have 2 speakers. We have Dr. Amber Mills and Associate Professor Paul Yates, and their full bios will be on our website. So I'm just going to briefly introduce them. Amber is the Policy and Research Manager at the Australian Association of Gerontology, AAG. And Associate Professor Paul Yates is a geriatrician, clinician researcher, and Acting Director of Research, Aged and Continuing Care at Austin Health. So today they'll be discussing research that explores the health impacts of climate change influence extreme weather events on older Australians, a really highly topical topic. And first we're going to hear from Paul. So without further ado, over to you, Paul.
Thanks, Bryony. Thanks for the introduction. Can I just check? Can I get a thumbs up if that screen share is working? Good. Okay, awesome. Yep. So yeah, thanks very much for having me. Again, yeah, thanks for the opportunity to speak today. Some of you might have heard me talk a bit to this before, and I guess this is some research that I conducted with some personal as well as, I guess, clinical and research motivation. The story for this research began probably in the late 2010s, when we were seeing a number of hot years, and culminating in 2019 when we had the terrible bushfires, amongst other climatic sort of events. And at the time, I was really despondent about what I was seeing and feeling quite powerless. With some colleagues, we'd got together to do some local work and to put together some local guidelines, including putting together a position statement for the Australian New Zealand Society for Geriatric Medicine. And during the process of consultation, as all position statements undergo for the society, we had feedback from our membership, which included comments to say things like, there's no evidence that there actually is a warming phenomenon, and that there's no evidence that warming is harmful, and that it is not the role of a geriatrician nor the Society for Geriatric Medicine to advocate in a political sphere, despite our efforts to make prominent the risks to our patients in our community. So this project was born of frustration and despondency, but feeling despondent about not being able to do anything to create any impact. So I've used some data that's collected, that's publicly available from the Bureau of Meteorology, and also our local hospital emergency department presentation data. And I give my thanks to some of the other people who've helped me with some of this, including Mark Song and Andrew Huynh, and Kristen Pearson, who helped with the position statement as well. So at the time of writing some of this background, we could attest that there was some converging scientific evidence that our human-related atmospheric changes were contributing to alterations in the global climate. And at that time, there'd been an increase in average surface temperatures of 1.18 degrees compared with pre-industrial times. This year, we've seen that actually we're nudging 1.5, which is this almost a tipping point related target that we're trying to stay within. And when we see increased global surface temperatures, we are witnessing greater climatic extremes, including more prolonged heat waves. And this particular project was looking at extreme heat events and our local context. So as you can see, for millennia, our carbon dioxide levels in the atmosphere had been within a reasonably tight-looking set of parameters, and you can see where we are now compared with pre-industrial and historic times. And it doesn't take a genius to work out that there's something very different about what we're currently experiencing. The term that's being used now is that we are in the Anthropocene, which is the era of human-induced climate. Just this week, we've seen media that expresses that our carbon dioxide emissions, despite some impacts and reductions in some areas, are still at record highs. There was a brief reduction during the pandemic and a brief reduction in our increase during the global financial crisis, but we are still pushing it up there and still producing much more than we need to be to improve our planet's health. When I presented this recently, this was the hot media, and it was people waiting to evacuate from Yellowknife in Canada who are experiencing their own devastating bushfires, greater than 6,000 fires and greater than 200 people evacuated. And the young and the elderly amongst the most vulnerable to these disruptions of their lives and their health. We saw that compared with any other year, the number of hectares of land burnt in Canada vastly outweighed what had ever come before. And these fires of a severity and intensity, just like what we experienced in 2019. And just today, we've seen some awful media to demonstrate some of the other most vulnerable amongst us. This is a story in Pakistan where this 3-year-old child weighs 1 kilo and they're supposed to weigh 11. The effects of climate change and the related catastrophes that have been experienced in Pakistan have shown floods from melting glaciers, heavier than usual monsoonal rains, and then droughts affecting at least 33 million people, which is more than half the population of Australia, of which half of those are, more than the population of Australia, of which half of them are children. So again, the effects of climate change are not a theoretical future problem that we need to do something about by 2050. We're seeing devastating effects worldwide now. The people that we in particular work with, so older people, are particularly vulnerable to the effects of climate extremes. With aging, the ability to maintain our temperature homeostasis deteriorates, and older people have reduced physiological reserve to external insult, as well as increased prevalence of age-associated risks, including polypharmacy and multimorbidity. So this puts them at increased risk of heat-related illness, and also the interaction and effect of heat on their comorbidities. As we mentioned, Australia's climate has warmed exponentially over the last 50 years, and our heat-related mortality is expected to triple by 2050. At the time of writing these initial slides, 1819 was our warmest year on record, and will be tipped to pip that now. There are heat health alerts that have been proposed based on mortality data, and they are sometimes location specific. So for Melbourne, for example, there are some heat alert guides. But I wanted to explore the impact of climate extremes on our hospital presentations in our local context, because we weren't sure if these alerts would necessarily apply in our local region. So this is a couple of graphs from a paper by Nichols and colleagues, and they reported that elevated mean and minimum temperature were the extremes that posed particular risk to older people, whether it's through poor cooling and disability, poor sleep, or the interference with the sympathetic nervous system. These box plots show residual death rates of per 100,000 people adjusted for long-term trend and season of people over the age of 64. And each of the boxes are each sort of 2-degree increase. And on the left, it's the mean daily temperature, which is the average of this morning's minimum and yesterday's high, and just the elevated morning temperature or overnight temperature. And you can see that once you get over 30 degrees mean daily temperature, and once you get over 24 degrees overnight temperatures, you start to see a significant increase in mortality of the realm of 17% and 21%. So I wanted to look at these type of extreme temperatures and our local emergency department presentations, the cost of emergency care, and mortality in emergency for Australians attending our tertiary hospital. As I said, I obtained data from the Bureau of Meteorology for our local weather station, 1 kilometre from the hospital, and our electronic medical records. I had weather data for 20 years. At the time of putting this analysis together, I had electronic records for 10 years, 2010 onwards. And I looked at emergency presentations, age, gender, episodes of bypass, and estimated direct care costs per triage category. I defined the extreme temperatures as previously reported in the Nichols paper that I just showed you, as well as some other parameters suggested on the Bureau of Meteorology, included elevated maximum and hot and very hot days. And I also, because I was looking at presentations rather than mortality, I did analysis looking for potential thresholds either side of the mortality-related thresholds, and also included other things like heat waves, so large duration of consecutive days of heat, or days where there was a very large shift in temperature of greater than 20 degrees, because that's been suggested to also have an impact. I used regression to determine the association between these parameters and outcomes, adjusting for these variables of age, gender, and bypass. And as I said, the main outcome was ED presentation, the secondary outcome was cost and mortality. So in the period of data analysed, there were just over 800,000 emergency presentations. And as I said, of those age over 65, there are about 225,000, a slight female preponderance. And in that group, the mean age was 78. This is the ED data mapped out, and you can see that there has been a significant increase in emergency presentations over that 10-year period. So time in the analyses was a significant contributor. These are the results looking at the impact of elevated mean daily temperature. And on the left, you have all patients, and on the right is just that over 65 group that I was particularly interested in looking at. And you can see that an elevated mean daily temperature over 30 degrees was associated with a higher number of emergency presentations for those over 65 and associated care costs. Elevated minimum temperature as well was associated with greater emergency presentations for that over 65 group and emergency care costs. But there was no significant association of elevated maximum temperature and presentations, which is again consistent with the previous publication. I also looked at consecutive heatwave events in current or preceding days, but there were relatively few and there weren't significant contributors. In terms of mortality, there were 500 patients who died within or prior to arrival to emergency. This was associated with greater age, but it wasn't associated with the extreme temperature events. So within the 10-year period of the data that was used for this emergency presentation data, there were 31 days with a temperature over 40 degrees, 23 with a minimum temperature of 28, 22 or above, and 17 with the high average. And the odds of all of these events increased by 10% per year over the 20-year period of data collection. So what you can see here is, in the early years, 2000, there were relatively few extreme events, but if you look, the frequency of these extreme events is increasing as you go across the period of reported data. So to discuss, I guess our local data corroborates the national and global findings related to mortality. In particular, elevated overnight or elevated minimum temperatures and elevated daily average temperature appear to be the categories that most significantly pose a risk for greater emergency presentations. And it's in the realm of 9 or 10 increased presentations or excess presentations per event. So on a day where an emergency department's always busy, it's not really very helpful to have a day of 10 excess presentations of frail, multimorbid, unwell older people any given day. But certainly this is something that is measurable in terms of its impact. We didn't see a significant association with elevated maximum temperatures or sequential days or change in temperatures. There's been some discussions as to why this might be, particularly in Melbourne. High temperatures may be followed by a cool temperature the following day, or it may be that people are more aware and modify their behaviour more if they know that there's going to be a very hot day, as opposed to being aware of the effects of a warm night. Why are warm nights so bad? Well, I guess they represent a period of sustained elevated temperature, and so that cumulative burden of stress on older people's physiology is longer. There's a difficulty in cooling down. As we mentioned, the older people have less sweat and less mechanisms to cool themselves. And it may be that as well that sleep is impacted, which can disrupt your sympathetic response. And there was a really lovely piece in the ABC just recently about some of this physiology, if anyone's interested in having a look. I did also look at whether or not the loss of cold days with warming, it might be a good thing, as some people have suggested. But unfortunately, within this reporting period, there were very few cold days to interpret the data, but these did appear to have a higher presentation rate. In terms of limitations, obviously it's a single centre. It's difficult to attribute deferred presentations and measure impacts subsequent to a day of heat. And because it's a single centre, it might not be as easily or readily generalised to other parts of Australia. But I guess that in itself is a strength, that we can use this to really target our local measures. And it's used particularly, the thresholds that are specific to Melbourne. And it's a very large sample for this particular type of study. So to summarise, we knew this, but for the purpose of this exercise, I felt compelled to really demonstrate this impact and present this to a wider audience, including the people that have come to me and said it's not a problem. We can see that there is evidence of a warming trend even in this data. There is evidence that this warming trend is having a great impact on morbidity within our older population in our local context. And so this isn't a problem that is happening or going to happen in decades from now. This is something that is affecting our patients, our loved ones, our health systems, even at this point. So not only do we need to be adapting to these problems, but really we need to be looking at what are the underlying mechanisms and really advocating beyond just dealing with the outcomes, and advocating to try and limit the cause of this, both locally and globally. we're now looking at system preparedness for extreme heat, and there's certainly local policies and policies across the country and at a state level. We're working more in terms of advocacy and action, and we're talking to some collaborations between some of the people in the room here today about what we can do to mitigate harm and really improve our advocacy. Within our local hospital, we've had a really greatly resurgent sustainability group. This data has been presented very widely, and a lot of us are now much more empowered to be advocates than we ever were before, knowing that our future depends on it. So I would like to thank everyone for the opportunity to present today, and very happy to take questions and suggestions and other people to join the call to arms to see what we can do to make this better. Thanks.
Thank you, Paul. Fantastic to have that evidence to support those advocacy efforts. And as much as I can see how this is an issue for emergency departments and hospitals, there are also all those people who don't get there. Yeah, it's just really such a critical issue. So thank you. And we'll take questions at the end. So we'll move straight on to Amber's presentation, and then we'll take questions at the end. But feel free to put them in the chat if you've got a question that you would like to ask, or a comment that you would like to make as we go through the presentations. Thanks, Paul. Over to you, Amber. Thank you.
Thanks, Bryony. Can I get a thumbs up that you can see my slides? Awesome, thanks. So welcome everyone, and thank you very much for having me today. Today's weather is topical, so I hope everyone's got a nice cool spot and a cool drink of water while we're listening to today's presentations. I'm the Policy and Research Manager at AAG, and for those who don't know who we are, the Australian Association of Gerontology is a membership-based organisation, and we aim to improve the experience of ageing by connecting research, policy and practice. Today, I've got a relatively short presentation for you about a piece of work we did undertaking a rapid evidence assessment on heat waves and their impact on older people in Australia. This piece of work was undertaken by a working group within AAG, and it forms part of our funded work by the Department of Health and Aged Care. So just by way of background, we can define a heat wave as when the minimum and the maximum temperature are unusually hot, and Paul's made reference to this in his slides, over at least a 3-day period in any one location. And as Paul's also beautifully outlined, heat waves are increasing in frequency and intensity, both in Australia and other parts of the world, and that we expect to see increases of between 10 and 50 additional heat wave days by the end of this century. So that's going to create a particular impact on our population. We've also already heard that there are particular risk factors for older people relating to their age, any pre-existing medical conditions, chronic mental disorders, social isolation, low economic status, homelessness, and perhaps engaging in strenuous outdoor activities. So those are particular risk factors for hot days. We also know that older people as a cohort are more likely to experience poor health and to be living alone with fewer social contacts and limited finances. And so they are a particular cohort we need to be concerned about with the increased prevalence of warm days. So the aim of this piece of work was to conduct a rapid evidence assessment to analyse the quality of research on the impact of heat waves in older people in Australia, and also to develop a set of recommendations for policy and practice. To do this, we took one paper as our starting point, which is this one published by Fountain and colleagues in 2019. It's a scoping review that covered literature over an 18-year period on older adults and natural or environmental hazards. And in that paper, we found there were 14 Australian publications that focused on heat waves. We updated the searching and found another 3 reports in the references of that original set. So all up, we undertook a manual analysis of 17 publications, synthesised them and assessed the quality of the evidence. In terms of what we found, most of the papers were published prior to 2015, and most of them were exploring the relationships between heat waves and any impact on older people, and then there were some descriptive studies as well. Most of them were covered on the, most papers published referred to research conducted on the Eastern Seaboard, so nothing published from WA or Northern Territory, which in consideration of the topic and their particular climates and experiences of long periods of hot weather, we thought that that was notable, but it may just be an artefact of this particular group of studies. Overall, we found the quality of the evidence was low to very low due to the risk of bias, and the quality of evidence and the techniques that we used are outlined in the paper, and I've got a link to that on my last slide. But just in brief, they're based on a Cochrane collaboration and PRISMA statements. But despite this low quality of evidence, we feel that the evidence does provide valuable insights into the impact of heat waves on older people, and also deriving policy and practice responses to the heat waves. In particular, and again, Paul's covered this really nicely, some of the reasons why older people might be considered particularly vulnerable to heat waves, as discussed in the papers that we reviewed, was that they may be concerned about increasing their liquid intake on a hot day, and that may relate to a perceived risk of incontinence. So that's, by that I mean that an older person may choose to not drink extra because they feel like it might contribute to incontinence, even though that may not be the case. Or they may be taking some diuretic medication, or they may have also received medical advice to restrict fluids, and so that might contribute to poor uptake of liquids. We know that ageing is associated with increasing comorbidities. And we also know that there are some socioeconomic factors or social factors that impact older people and their vulnerability to heat waves, such as being socially isolated, experiencing homelessness, having a low income, etc. In terms of recommendations that we have pulled from the 17 publications that we reviewed, we have the following. So first of all, it would seem sensible that Australia develops a national climate change and health strategy. And in fact, one was just released last week, which I'll talk about shortly, which is really pleasing to see. We think that there should be organisational heatwave response plans. And again, Paul has covered that in his talk from some of the things that his health service are doing. And we know that the Department of Health in Victoria and other states, for example, have such response plans. Educating staff and volunteers, older people and their families and carers would seem to be important. This one is a bit contentious and there are mixed views on it, but potentially a register of older vulnerable people, so that we know that when there's a heat wave, there are certain groups or certain individuals that we might think we should reach out to see if they need additional support. But of course, there are privacy implications in that. Additional contact with older people during heat waves would seem a sensible thing to do to, again, check in, see how they're doing, see if they have additional support needs and what they can be connected to. And one thing that they might be connected to, for example, that could be useful are cooling centres for older people. And these could be in locations such as hospitals or residential aged care facilities or other public utilities such as libraries or even museums. Outreach programs for older people experiencing homelessness would seem important, and facilitating access to air conditioning in at least one room for older people. So some of the research shows that if you can put air conditioning into just the bedroom in an older person's home, that will go a significant way towards reducing the impact of the heat wave, but also not creating too much cost for the individual household to bear. So you don't have to air condition the entire house, but just the bedroom, which of course then helps with sleeping and rest periods. We need to develop as well specific prevention strategies for older people with medical conditions that place them at higher risk during heat waves. So this might be some of the information that's used to inform an outreach program, for example. And nuanced health messaging about hydration for older people. On the previous slide, I mentioned there might be a perceived risk of incontinence if you drink more on a hot day. And so some targeted and specific messaging about that risk or perceived risk would be useful. Backup strategies are always needed for everyone in the community, but particularly for older people if power supplies are interrupted during the heat waves, especially if we're advocating the use of air conditioning. That's only as useful as the supply of electricity, of course. Improving urban planning and building design is a good longer term strategy to address thermal comfort of older people during heat waves. At a previous AAG conference, we had a presentation from an architect about building design that noted that in the Southern Hemisphere, our building codes typically restrict the opening of windows for safety considerations, but it also has a secondary impact on airflow, which is of particular importance. And finally, like any good research paper, we need more research about older people and heat waves in Australia, but I'll come to that shortly as well. In terms of the impact or what we've done post-publishing our rapid evidence review, AAG is a member of the Climate and Health Alliance, or CAHA, participated in consultations on the National Health and Climate Strategy earlier in the year, and this strategy was released by the department last week. In our submission, we emphasised the need to consider the impact of climate change and the needs of older Australians in particular. We also positioned that an evidence-based approach is really vital. In our experience, sometimes policymakers and departments within government may express a desire that they'd like to be nimble in their decision making, but we really emphasised the important role of evidence-based approaches. And finally, we're really pleased to announce that late last week we received a funding outcome which was successful with partners with the Melbourne Ageing Research Collaboration. We're going to be exploring the use of cooling centres by older people during heat waves. So looking at the feasibility and what are the factors that might impact uptake of those facilities during heat waves. So thank you very much for your attention today. If you're interested in reading the full report, there's a QR code there, and I know this is being recorded, so you can always come back to it later. And if you've got any particular questions you wanted to follow up, that's my email address. Thanks.
Thanks, Amber. Fantastic to see that evidence review. So, any questions or comments? Yeah, while you have a think about it, I might ask a question. So I guess it's a question that comes from my own personal experience. And I understand all the risk factors that you've been talking about, but this is a question for you, Paul. One of my mum's friends on a 40-degree day went and had her hair done, sat in her car and died. So why would heat cause an older person to die? You know, I mean, it may not be the heat, but you know, if it is the heat, why would that happen?
Yeah, look, it's tragic, isn't it? And we don't always think about what heat does to our bodies. And I will say that if my explanation or answer to this question isn't very good, there is, like I said, a very, very well-written piece about the effect of heat in lay language on our bodies, and a couple of case studies within this article. It was only published within the last couple of days, and if I was clever, I would have had it in front of me right now so that I could be reading it in a very eloquent way. But heat causes a lot of impact. So I guess our body has evolved to be working within a tight parameter, sort of range of heat parameters. Our cells, our enzymes, all of our processes within our body are designed to work within a certain range. And we have, I guess, mechanisms of homeostasis that we can put into action to keep our systems within, keep our temperature within that range. But they are vulnerable to, I guess, being less efficient with aging. So, for example, with aging, we don't have as much, we don't sweat as much, and they can sometimes have their own problems. So, if you get hot, you might vasodilate to allow greater cooling through the skin. But of course, that leads to lowering of blood pressure. So if you have a low blood pressure, then it might cause you to faint or have insufficient blood supply to other vital organs. So each adaptation or homeostatic kind of mechanism can have its own problems as heat causes sort of dysregulation, or there's impacts of aging physiology. The other thing that is provoked by higher temperature is our sympathetic nervous system starts to kick in as it's a somewhat stressful situation for the body to be in, and so we become more tachycardic. Our stress hormones increase, the heart beats faster, and these things are pro-inflammatory and also can lead to things like coronary artery complications, or we might have movement of electrolytes with dehydration, loss of electrolytes, and that can cause things like arrhythmias. So many problems, and I guess fluid shifts can occur into the tissue that can then again affect the cardiac performance. So I can see that the situation you're describing is a perfect storm of unfortunate sort of circumstances and decisions. Did she have her hair done in a set, you know?
Yeah, I don't know. Possibly she was already
with the heat on to set the perm.
Yeah.
I think I was imagining that all of the things that could go wrong. But one might think that it would be a nice thing to get your hair done somewhere in a cool place, in a shopping centre. But then again, being in air conditioning can also be very dehydrating and drying. So the things that we do to protect ourselves also need to be mindful of the unanticipated effects of those as well.
Well, that's a perfect segue to one of the questions in the chat. I can just see them all now. So there was a couple of questions about when will the project for cooling centres be undertaken? But I'll move on to the question, are there health risks associated going from cooling rooms back to the heat? Do these participants need to take extra precautions? So again, I'll leave that one with you, Paul, but I'll move on to some other questions for Amber and Atik.
So look, I think rapid shifts in temperature, certainly we wouldn't be encouraging that. And so, yes, there would probably be risks. I'm not really across the data on cooling rooms specifically, but certainly if you having rapid effects on the cardiovascular system, if you've got an older sort of older physiology that's not quite so robust and to compensating, then certainly there are risks of problems like low blood pressure if you go out into the sudden dropping of blood pressure, other things. So certainly, if we're going to be talking about cooling rooms or cooling places as a widespread sort of public health strategy formally, then I think we really need to understand where we could inadvertently cause harm if it's being sort of encouraged across the board. And I think there's a lot of people that have informally used things, and Amber will speak to this, I'm sure, that types of cooling rooms informally through visiting the local shopping centre or something on a day, or going to the movies, or that might be one strategy. And then there's the formally encouraging it as a as an intervention to reduce harm, which
Yeah,
is a
yeah.
slightly different thing, isn't
Slightly
it?
different. I remember the Black Saturday bushfire day. I went out to Doncaster, spent the day in the shopping centre, oblivious to the tragedy that was unfolding. Amber, so there's a couple of questions about the project particularly. So first one is, when will it be undertaken? And then the second one is, are the cooling centres planned to be in new buildings, or is there room for other facilities to be temporarily repurposed?
Sure, thank you. So the project is due to run next year, so in 2024. It'll be based in Melbourne, and the intent is to use existing facilities rather than building new buildings. So we are going to explore the use of community utility spaces like libraries or museums. It could include shopping centres as well. So it's somewhere where there is already space for people to come and spend time, and then it's already a cooled place because it has its own air conditioning system. And the point of it is to provide a space for someone who doesn't have access to cooling at home, or whose house is not cool during a heat wave, to come and seek some relief to avoid the kind of health impacts that Paul's just outlined. In terms of, are we creating more problems by cooling people down during the day and then sending them home to hot houses? That's something we'll need to explore, of course. Equally well, that recommendation that I mentioned on the slide of all the recommendations, if you recall, there was a paper that we reviewed that showed that if you can just cool down the bedroom, that doesn't impose too much additional cost, and it has been shown to have positive impacts on health. That's about providing a space for respite from the heat during the day, but also remember that we're talking about extreme temperatures during the day, but also elevated temperatures at night. So at the end of a hot day, to then go and try and sleep in a hot room when you've been hot all day isn't good for your health either. So it's about providing a cooler environment to be able to get your rest and let the body recover from that hot day as well. Are there any other questions related to that project?
Well, there's another question not really related to the project, but just that I think you might have a view on. Do you think rental laws will change to make the facilities or the ability to cool down a house to a safe temperature mandatory?
Potentially, and I think there's also potential for changes to building codes to ensure that the new homes that we build are well suited to our environment. So things like having some kind of veranda that provides a buffer of shade around the house, potentially changes to the building code around the amount or the width that a window can open. There are, of course, safety considerations, but I think it's also timely that we consider the fit for purpose design and the ability of a house to encourage airflow, given that Australia already has a warm climate, and as we've outlined, it is increasing and is going to increase further in terms of hot days. So changes to rental laws and building codes, I think, are inevitable, and that's I guess that's where I see the importance of the evidence bases that Paul and I are presenting on today in shaping the discourse and the public policy making by government in response.
For sure. So there's an interesting question here. Is there currently any framework around assessing extreme weather resilience in aged care assessment? I suspect not, but is there room to potentially add this in? I know that, sorry, is also limited. I just can't see the writing. This is also limited room in aged care packages for cooling and air cons. So what are the best ways to negotiate this? No, Paul, would you like to respond to that?
Yeah, look, I don't know the answer. I think that there would generally be risk assessments. I don't know if there's specific assessments of resilience to extreme weather. I think it's a really important thought, though.
Yeah.
And I think it might be somewhat service dependent and location dependent in terms of their their level of that this is on their radar.
Yeah.
I'm sure that in certain places this would be very much a risk that would be standard, but other places I suspect not. I'm happy to be educated if someone or involved with community ACAS can speak to this. I'd be curious to know.
Well, there is some answer from Ellie, at least on the ability for you to get support for cooling if you're on a home care package. She says, I'm a community aged care OT and used to do lots of support letters for home care packages to fund split systems for clients in high-rise flats with no cooling. But the home care package guidelines now state that the cost of cooling, installation and repairs is an exclusion. And could this evidence change the guidelines? So, yeah, I don't know that. I think we would certainly hope that it would, but I'm not sure that we've got the final answer on that.
Yeah, I'd agree, Bryony, and I think again that's where the call for more research evidence and target questions like that is really important.
Yeah, and just there's a response from Sally to the question about assessment, resilience assessment, saying it's not currently in an ACAS assessment. Then there's just one comment. I always feel sorry to see the tennis players during the Australian Open grinding during the hot days. I agree. Are we sending the wrong message to our older population about it's fine to be outdoors in the heat? Take that as a comment.
I guess there's it's an interesting message for the community, isn't it? That these are extremely, what do you say, well-honed athletes, and I guess that what they're doing is a bit different from just trying to survive, but they're putting themselves through extreme exertion. But I think that it has become noted that they've had to stop games and they've had to stop have days where they couldn't play because of heat. It's become increasingly in the media that the timing of the Australian Open is not popular amongst some people because of the conditions that players have to play in. And I think that you can have an air-conditioned court with the roof closed, which is great, but the rest of the stadiums and outside courts are just not going to be conducive to playing or watching. So I think that they've talked about the need to possibly change the date of the Australian Open, which is unheard of. Maybe these sorts of impacts would actually make people take notice. I don't know.
Yeah. And
I
there's
think
another
it's also
comment on that. Sorry, go Amber.
I was just going to note that those tennis players also have a care team around them who are very carefully monitoring their physical well-being, which the average person doesn't have. So it's absolutely the wrong message, I think, to be sending. And again, I think that's where there's a need for some of these more nuanced messages about what's safe to do on a hot day or in a heat wave across the entire population, not just for older people.
Well, just further to that, Katrina says, when I worked as an ED nurse, we would often get runners who had collapsed in races, training, etc., during extreme heat. Very risky behaviour. Any other comments or questions before we close?
Just this has made me think about a time when I was, I guess when I was in my training, when we had some others have heard me speak to this as well, it was during that 2009-10 summer, I think it was, where Melbourne had a particularly warm run. At that time it was about a 5-day heat wave, and we had an influx of vulnerable older people whose decision making wasn't very good in the heat that came into hospital. And so we saw a whole lot of people who hadn't had very robust coping strategies or hadn't had the cognitive wherewithal to protect themselves during the heat, and all had sort of emergency presentations, and a large number of them remained within the hospital because it became apparent that actually they were struggling for some time, but this was the straw that broke the camel's back. So I was just thinking the impact in that particular situation wasn't just the presentation, but it was also long length of stay, because these were people who then got stuck within the hospital system as they went through things like VCAT to try and get them placed. So I guess the ripples of these are not just necessarily a single presentation or event, and a heat-related presentation can sometimes be the first of the first sign that people are actually struggling with their decision making. So I guess as a practice point to any clinicians in the room, just to thinking about the older people that are presenting with heat, that it might not just be their cardiovascular physiology that's causing their the presentation, but also might their underlying cognition and decision making could also be vulnerable.
Yeah, really good points. Yeah.
And I think that sometimes a hospital admission for an older person is a point where the rest of whatever's happening in their lives comes to the fore, and there may be other things happening in the background that have been as yet unassessed, and the same goes for the heatwave related ones, but you probably get them on a greater volume all at once. I think there's also scope for the next version of our cooling centre project to potentially look at what information and resources can we supply within a cooling centre. So if you've got people coming into the local library, for example, is that a good time to then bring in some community services to talk about some information about how to manage during a heat wave, what other resources and supports there are in the community, connecting people in with their neighbours where possible, and possibly also bringing in some healthcare teams to give some information about being careful in the heat. So that's another option for us to explore as well.
Another opportunity for
I think, I think that's a fantastic opportunity to really capitalize on the market, so to speak, and look at what health promotion interventions, risk reduction, general preventative healthcare that we could try and implement whilst people are going through the cooling centre process.
Fantastic. Well, thank you so much, Paul and Amber, for your fantastic presentations and for drawing our attention to this such an important issue, and an issue that's going to become increasingly important, sadly, in the next decade or so. Getting some nice thank yous in the chat as well. And I'd also like to thank everyone for their questions and comments in the chat. And thank you for attending the Seminars in Ageing program for 2023, hosted by NARI and the Academic Unit for Psychiatry of Old Age at the University of Melbourne. We've had amazing presentations this year. We've had amazing numbers coming, actually. We've reduced the frequency to monthly, and that's actually increased the numbers of people who have been attending, which is very interesting and probably represents the really high quality speakers that we've had. Our 2024 program will begin in February, and we'll soon be sending you the program for next year. And just finally, I'd like you to use your clap reactions to thank Paul and Amber one more time. Thanks, everyone. All those cute clapping hands.